The content provided in this podcast is for informational and educational purposes only and is not intended as medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition.
Is it my story, your story, his story, her story, Jane's story, Joe's story? Is it just an allegory? The show's about to start and we still don't have a name for it. Pop, 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 pop. It's a long story.
Aging and cystic fibrosis are words you don't always hear in the same sentence, but on this podcast, you'll hear them all the time, with relevant discussions and unexpected explorations wherever this podcast might take us.
So many people with CF are living longer thanks to modulators and medical advances. We thought it was time to get into some real conversations with expert guests and people from all walks of CF about what living longer with CF means, the good and the not so good.
I'm Dr. Ahmet Uluer.
And I'm Lauren Harvey.
I'm a medicine and pediatric trained pulmonologist and director of an adult CF center at a Harvard-affiliated hospital right here in Boston.
And I've had CF all my life and was recently diagnosed with CF-related diabetes. I am committed to creating a supportive space for those with CF and their loved ones.
I will bring the medical expertise and provider perspective.
I bring the real-life CF experience.
And together we bring you It's a Lung Story, a monthly podcast about aging with cystic fibrosis, where we take a little time to tell a lung story.
It's a long story.
It's a lung story. All right, how much do we love that song? This is our first podcast, and I know that they always say that your first podcast is the most challenging one, and it may not work out the way we want, but this is happening. I'm Ahmet Uluer.
Hello, I'm Lauren. I'm super excited to be here. First ever podcast. So I have cystic fibrosis and I have cystic fibrosis related diabetes. So I'm here to bring patient perspective from a younger standpoint. And we also have Andrea here. Andrea, oh my God. I was putting emphasis on your name.
Just get that
Andrea
here. Right off the bat
It's
is how we pronounce my name.
Andrea.
Okay.
You
so
know what? I
hard to
can't work
pronounce
with these
that.
conditions.
It's
I can't
really
work under
hard.
these conditions.
I'm Andrea Gavin Becker. I am the producer and creative director here on this little podcast. And I also have cystic fibrosis and CFRD and a host of other things that we'll probably talk about on future podcasts. I represent the older section of aging with CF and delighted to be here.
Well, you guys, first of all, I am so fortunate to be able to co-host this with Lauren, and our producer, Andrea, brings such a gravitas to our podcast, and I can't wait to see where we go with this. I do want to send a shout out to the person who composed and sang our intro. We're talking about Noah Dinerstein, who is a singer, songwriter, and influencer. And you can follow him on Instagram, Facebook, TikTok at Live Noah. And he's just an incredible guy. And he's my cousin. And he's just also hilarious. So maybe one day we are absolutely going to bring him on and we'll have a conversation with him.
And maybe a song.
Definitely a song.
We can all sing together.
We're gonna get the long version as well of the song. So this podcast is inspired by people who are living longer and healthier. And whether you're on modulators or you're not on modulators, we know that people are living longer. And we are really interested in hearing about what it means to age and have cystic fibrosis, and what we need to know about what are our expectations of aging. And we have Lauren, who is going to give a perspective of someone who is entering adulthood and who is an adult. I know you've entered adulthood a while ago.
I am an adult.
but
I'm 24.
Yeah, I wasn't going to say your age, but yes, you're a full-fledged
Sorry, I'm
adult.
not 24.
You are, wait, you're not 24?
I'm in my 20s.
Okay.
Does that work better?
Okay. No, I was going to say 24 is fine. I think 24, I think all of us here are really wish we were 24. And Andrea is a little bit older, just barely. And so she's going to bring a perspective of someone who has a few more years under her belt with cystic fibrosis. There are going to be a lot of different topics, and we're looking forward to touching on lots of different things that people are dealing with as they age. And so we look forward to touching on those topics with you. Today, we're going to be hearing about CF-related diabetes. And with that, I am so delighted, and I can't believe I just said delighted. I'm super pumped. And okay, forget I said that either. I am so grateful to introduce you to my good friend, Dr. Melissa Putnam, who is brave enough to be the first guest on our podcast. It's a long story. She is a medicine and pediatric or med-peds trained physician like me. That means she sees both children and adults and is one of the leading endocrinologists studying cystic fibrosis. She was invited as a plenary speaker at the 2024 North American CF Conference held right here in Boston. And I would like to share a fun fact right off the bat and share that she is a twin and a mother of twins, and her twin sister also had twins.
Yes.
So how cool is that? And perhaps that's what this podcast should be about. So Melissa,
Twins are the
welcome.
best. Yes. Ahmet, I am delighted and pumped to be here today.
Love it. I knew those were good words. I knew those were good words.
Yes, no, I really appreciate this opportunity, and I love the different perspectives that everyone is bringing to this talk.
So
This is
first of all,
great.
did I get it right with all the twins?
Yes. I'm an identical twin. My twin has twins, and I have twins.
Unbelievable. I said it
know.
and I knew that, but I still can't believe it. It's just really amazing.
That's crazy. I'm guessing there's never a dull moment.
No. But the best is Halloween because we can all coordinate our twin outfits, and yeah.
Did you guys ever do like a Parent Trap thing, or is that like another episode?
Oh, yeah. We've never been able to pull it off. Yeah, I know.
Next
Well,
year.
No, parents know.
Yeah.
Parents know.
We do look more alike as we get older. Maybe someday. Actually, I guess you don't really know it's me. Could be my sister. You wouldn't know.
Who wouldn't know?
Your kids are going to try to pull that off. And with the
Wait, you're Melissa's sister
the
right
cousins.
now. You're gonna get your clock cleaned because you won't know any of the.
I
answers to
know,
these
yeah.
questions.
Well, listen, we've got a lot of ground to cover, and we're not going to get to everything, but hopefully we can get to as much as we can. So let's get started. And we all know, those actually who know about cystic fibrosis, family, friends, providers, we know that the pancreas is a big problem. And I know that close to 90% of people are born needing pancreatic enzymes to more properly digest their food. And most of the cells of the pancreas are responsible for that job, for the secretion of enzymes and digesting food, while only a fraction, like 3% of those cells, called islet cells, are responsible for controlling blood sugar. Yet the diagnosis of CFRD comes much later. And when it happens, it's close to 40-50% of people by 40 or 50 years of age. So I guess my first question to you is, why doesn't everyone get diabetes right off the bat or earlier in life?
That is the $1 million question, Amit. It's a little bit more complicated than the exocrine. So that's like with the enzymes. The endocrine with the beta cells in the islets, it's a little bit more complicated. It seems that we're learning a lot still about why this happens, but it seems that the beta cells, which are the ones that make insulin, they're there in the pancreas in people with CF and even in CFRD. And actually, they've done studies to look at people with CFRD and without CFRD. And the beta cells they look the same. They're just not working. And we don't fully understand why that is. And there are studies ongoing to try to figure out why that is. But what we know is that there's this progressive decline in insulin secretion and beta cell function that happens over time. And some people earlier, some people later. And it can be really hard to predict who is going to get diabetes when. So, yeah, I wish I had a better answer to that question. It's a good one.
And the plenary in 2024, and people can actually find that on YouTube. You do talk about this, and one of the other endocrinologists also talks about it. And so I do, if you want to learn more about that, please refer to that, go to that YouTube on the plenary session of 2024 NACFC.
I love the last question because my brother and I both have cystic fibrosis, but only one of us got diabetes. So we are like that 50-50. And it's so fascinating to me. But I guess our next question would be, what are the specific risk factors associated with developing diabetes in addition to time and age? And why are some people with CF more susceptible than others?
Oh, you guys just ask all the good questions. So the biggest one by far is having exocrine pancreatic insufficiency. But the interesting thing is even people don't have pancreatic insufficiency, so their pancreas still works, they still have. So it's a smaller risk, but they still have a higher risk of diabetes. So that's probably the biggest one. Age is the next one. The other risk factors that we think about are there's some studies that maybe genotype can play a role. More severe genotypes can be associated with diabetes earlier. A increasing risk factor that I think we're going to be seeing more and more is, so we know that people who have their genetic traits that predispose to type 2 diabetes, so if they have a family history of type 2 diabetes, that can actually be a risk factor for CFRD, which is fascinating and really a hot area of study right now. And so I think what we're also going to see then, similar to that, is that rising rates of overweight and obesity is going to be a risk factor too for something that looks like CFRD and looks like type 2 diabetes. And I think that I have my own like personal hypotheses that when you stress your beta cells by having lots of highs and lows or having to take steroids a lot, which makes you really insulin resistant, some of these things, having worse lung disease, which causes more inflammation and more insulin resistance. These things that make your beta cells have to work harder are likely to also predispose to having abnormalities in blood sugars and then go on to develop diabetes.
Melissa, what about gestational diabetes? Is that the first sign? Is that if you get that, you're more likely to end up with diabetes?
I think we don't really know exactly in CF because the numbers have been pretty small. We know in the non-CF population that gestational diabetes is a risk factor for developing type 2 diabetes. And I suspect also that same thing holds in people with CF as well. Yeah.
Obviously, I have CFRD, as I said a couple minutes ago, but even I have trouble differentiating between CFRD type 1 and type 2. What are some characteristics that are similar between them, and what sets CF-related diabetes management apart from type 1 or type 2?
All right, stop me if I start talking too long because I do have strong opinions about this. Let's think about them in on a scale. So type 1 diabetes, autoimmune, the immune system attacks the beta cells and completely destroys them. Typically presents in childhood, young adulthood. Insulin needed. If you don't take insulin, you can die. You don't make any insulin. Type 2 diabetes, you have an increasing insulin resistance over time. And so your beta cells make insulin, but they just can't make enough insulin. And so CFRD is somewhere in the middle. And it's a little bit like type 1 diabetes because it's an insulin deficiency state. But it's not type 1 diabetes because people still make some insulin. And so they're not at risk for the same kind of complications as type 1 diabetes, like diabetic ketoacidosis and things like that, where you have no insulin at all. It's also shares some characteristics of type 2 diabetes because there is insulin resistance in CF from inflammation, from treating with steroids, and that can actually go up and down depending on someone's health status. And so, but it is its own kind of unique type of diabetes that's very different. And I will say when we look at people with CFRD, if we look at their blood sugar tracings, they have a pattern that doesn't look at all like type 1 or like type 2 diabetes. It's this pattern where a lot of times fasting overnight, blood sugars can be okay. And then, but there's these big excursions that happen where the blood sugars go really high after eating and then come crashing down and sometimes even go low. And so there's this spontaneous, we call it reactive hypoglycemia, low blood sugars that happens in CFRD. And it's really that pattern. I don't think I see it anywhere else. And yeah, does that answer
Yeah.
the question?
Yeah. So when is it going to be called type 3?
I know. Technically, there is a type 3, and it is because it's like this pancreatic diabetes, but I almost want to call it like, yeah, I don't even know what we would call it. We
Yeah,
should give
we
it
have a nomenclature. We have to explain it all the time, family, friends. What is it like type 2? And it's easier to say, yeah, it's like type 2.
a.
That's
But if
true.
we could have our own type, that'd be great.
I wanted to tie
Yeah.
that, bring that back together though. So you said, or bring that back, you mentioned reactive hypoglycemia. And I think that it would be really nice for you to talk about when people have to start thinking about, is that related to diabetes? And I wanted Lauren, can you tell us about how you what were the first manifestations that now, even looking back, that you thought, okay, that was a sign of diabetes. I just didn't realize it.
It took me a while to register what the symptoms I was feeling were. I was tired all the time, I believe I was 19 years old when I was diagnosed. And for a 19-year-old, being tired all the time as you're in college and it's a new place, you're making new friends, I didn't really understand. I thought it was just the whole college experience. I was going to be tired from everything. But I realized no one around me was tired like I was. And so I would have to take naps throughout the day. And I was trying to play tennis at the time, and I'd have to sit out and just catch my breath. So really, the fatigue was the main one for me. And then the other one for me is my lung function decreased significantly. So once I did that, I was like, okay, there's something seriously wrong. And at the time, I didn't know I could get diabetes. And so I didn't really know what was going on. I thought it was just a cold or something going on that I got from college. And so I am curious, Melissa, what are the earliest signs of CFRD that people should look for if they haven't been diagnosed yet? And is there anything we can do to avoid it or delay it?
Oh my gosh, I love this question. So, early signs, I think the biggest challenge of CFRD is that a lot of times there's not a lot of signs. I think the ones that we focus on the most are weight loss is a big one, or in kids not gaining weight, a decline in lung function, or an increase in the number of CF exacerbations can sometimes be a clue that something is happening. A lot of times, the symptoms that we typically think about with diabetes that we might think about with type 1 or even type 2 would be peeing all the time, thirsty all the time, eating all the time, but losing weight. Some of those don't really see those as much. And that's one of the reasons why screening is so important. But our screening tests are really crappy. I'm not going to lie. So I think, and that's definitely something that we're trying to work on with in research. But yeah, so I think many, if not most people will find out they have diabetes, not because of symptoms, but because of screening. And in terms of prevention, I wish so much that we had a way to prevent CFRD. It's really hard because we don't really know why this dysfunction is happening in the beta cells. And because it's hard for us to predict who it is that's going to get diabetes. There's no medications. There's really nothing that has been shown in the studies that can actually prevent diabetes from developing. That said, what I tell people, and this is completely anecdotal from just seeing a lot of people with CF and talking about these things, I do think that paying attention to healthy nutrition, to exercise, to keeping weight at a healthy point, not too much, not too little, like avoiding really high sugar foods, things that are going to make your beta cells work a lot harder. I hope that potentially that might help push things off a little bit, but ultimately we just don't know.
Yeah, I was wondering about that. We often, like, if we see a hemoglobin A1C rising, that is one way to monitor average blood sugar. We will say try to avoid high carb meals and try to make sure that you have a diet that has fat and protein in it with a high glycemic index to make sure that is something that you can do to hopefully delay it. So I'm heartened hearing that because it is often what we'll tell people as well. And hopefully that will do that.
And I also think that I'm not sure it'll stop the diabetes from
Right.
happening, but I do think that it might help push off the need for insulin. If pulmonary function is good and weight is stable, a lot of times we can keep an eye on sugars and see if potentially staying off insulin could be an option. It's a lot harder to do that if you're having blood sugars go really high because you're eating a lot of sugar. Then it's a lot harder to try to balance it. So, yeah.
And maybe a quick answer for this one as we try to move on is reactive hypoglycemia. If you see someone who is presenting this way and has been having to deal with this, is that eventually someone who's going to end up having diabetes, or is that really not a clear marker?
So I can give you what's in the literature and then I can give you my personal opinion. So what's been studied is that that they've been studies looking at reactive hypoglycemia often after an OGTT, which is challenging because even people without CF will have low blood sugars on an OGTT. So it's really hard to know for sure. But there are some studies suggesting that no, reactive hypoglycemia on an OGTT is not a predictor of diabetes. But I will say that just from reading a lot of CGMs and a lot of people, that if someone is having really high blood sugars that come crashing down and cause the low blood sugars, that is very common in that kind of early abnormal glucose tolerance / early CFRD. And I do think that those people are at a higher likelihood of progressing. I'll also say sometimes what we've tried, ironically, to try to prevent those low blood sugars in people who are having highs and then lows, sometimes we can try an ultra rapid acting insulin before eating so that the blood sugars don't go so high and then they may not go so low. But you have to be really careful when you do that. But otherwise, there's not a lot of things that we can do to make that better. We can try diet changes, which is what we usually do. Frequent small meals and snacks with balance of carbs, fat, and protein. We can try some medications that it can inhibit carbohydrate absorption. And we can try that, but a lot of GI side effects, which is really hard to sell to someone since GI side effects are really common in people with CF already. But otherwise, it can be challenging to manage.
Yeah, I was going to say that seems really genius to try a little low dose insulin, but in someone who's having blood sugar that drop, that seems like a hard thing to ask.
Yeah.
Hard thing to ask someone to do. Now, I was just going to say that having people who are aging, they are thrilled. It's really wonderful, but they always feel like the other shoe is going to drop. And especially when things are going well, getting CFRD is one of those instances where people feel like the shoe is dropped and it's something that now new they have to deal with. And especially bad is when you're dealing with chronic symptoms or lots of challenges in your health. And Andrea, I do feel like this is where I'd love you to chime in and talk to us about when you were diagnosed and how that impacted you, both physically and emotionally.
I was diagnosed just a few years after I had a lung transplant. So I had a couple of shoes drop already. So I did not have my eye on the ball on that one. And it never occurred to me, maybe you should look into this extreme thirst. But it was New Year's Eve when I went to clinic. And they were like, you might be pre-diabetic, so you'll probably have to start practicing on oranges, how to give yourself insulin. Just to be safe, we're going to send you down to get your A1C checked or see what your blood sugar's at. And I got a call at 6:30 on New Year's Eve, and they were like, so your blood sugar's 575. And normally we'd bring you into the emergency room, but since you're they knew I was super responsible. We just called in a script. So go pick up your monitor and your whatever, learn how to do a finger stick, give yourself a shot, and happy holidays. So it's no reflection on the nursing staff that were working late on New Year's Eve or anybody. It was shocking to be sitting there at 10 p.m. The day before I was thirsty, and the next day I was Like my mom came in, like I'm 28 years old or 30 years old. And I'm like, Mom, not that I couldn't figure it out, but it's just a lot. And my blood sugar I was out of my mind and I didn't know it. But yeah, it was a gut punch for sure.
So, Melissa, mental health, what do you recommend to people? How do you counsel them, support people, especially as this aging population may not be expecting diabetes? What do you recommend there? Because that's a lot for someone to
Yeah.
handle.
I mean, I will say, having delivered that diagnosis many times, it's so hard. And it's the reason that I went into research in CFRD, because I'm like, we need to make this better. Like the burden that we put on people who already carry so much with the lungs, all the other treatments, and your lung transplant, which, by the way, is also a big risk factor for CFRD too, that it is overwhelming. And what I try to do when I have a patient coming in who is getting this new diagnosis is really focus on where they're at. And people react very differently to news like this. And then just baby steps if we need to, bigger steps if we can. But overall, that we're a team, we're going to be in this together. We will help take care of this. I think setting up, making sure there's a support system around as much as possible. You said what your mom was there, like having family to help manage all the information. It's like drinking from a water hose. You're learning insulin and carb counting and fat and all these things. Having someone else to help remember some of these things and to support you throughout the process. I think also having a referral to a psychologist, a therapist, someone who understands diabetes and what it adds. Um, I think all of that is important because it really is um, just adding so much.
I think different people have figured it out differently, but how many decisions you have to make an hour in your head. And I figured it out once that I was making like 25 little things that you don't think about. That piece of it, that mental piece, especially as you get older, is rough. It can be very rough. And to have a supportive spouse or family member takes a lot of the burden.
I had someone once tell me that the hardest part about diabetes is it never goes away. It's always there. You're always thinking about it. It's blood sugar too high? Is it going low? When you eat something, you always have to think about it. And you're thinking about so much other stuff too. It's a lot.
I
That's
will
exactly
say
it.
the one perk is my math skills have never been better. The carb counting has really increased my math skills. So I'm thankful because that's always never been my strong suit. And now I feel like I actually understand math a little bit. So I guess there is a little perk. It's not great, but it's something.
I think it says
I'll quote you on that one.
and we're
Oh,
learning
that-
we're
love
learning
it.
about Lauren, and I feel like glass half full. I love your approach.
Yeah, I
Yeah.
was always a science person, never math. And now I feel like I'm more math than science sometimes.
That was your approach to life. Yeah.
Yeah.
It is helpful to know how many carbs are in everything.
Yeah, for sure. Or how many carbs are not in something. There's plenty of things that I've thought there's carbs and then I go low because I give myself a shot and there's not any carbs. And it's interesting to learn what has carbs and what doesn't. On another topic, many people with CFRD are traumatized by hypoglycemic or very low blood sugar events. And this can impact the way somebody manages their blood sugars for years. I was one of them. I was very traumatized by my first ever low and thought I was going to die. And obviously, I'm still here. So it's not as bad as you would think unless you let it get that bad. But when I was diagnosed, I remember being told to make sure that my blood sugars don't go too low. And I don't remember as much stress being placed on higher blood sugars. So, can you tell us what the urgent dangers are that I should be aware of with high blood sugars?
Yeah. Oh my gosh. No, it's so true. Especially early on, when you think about blood sugars, the low blood sugars, they are scary. You feel terrible. You're shaky, sweaty, and you're nauseous and feel like you're going to pass out. And there's a risk of passing out and having a seizure if it goes too low. And it's crazy to think about it, but insulin is one of the most dangerous medications that we prescribe, yet you just send in a prescription, people fill it and go on their merry way. So but lows can be really scary, and highs, you don't feel it as much. And if your blood sugars go really high, especially if it's sustained over days, then hours, days, really not hours, more days, you can start to get dehydrated, especially when your blood sugar goes above 200. You start to lose sugar in your urine, and that drags water with it. And so you can start thirsty and getting dehydrated. You can also, if you're losing too many calories that way, you can lose weight, which we worry a lot about in people with CF. And sometimes people will say that if their blood sugars go really high, they feel foggy or blurry vision. But a lot of times people really can't tell so much symptom wise when the blood sugars are high. It's really the long-term effects of the high blood sugars that we're most concerned about rather than just the short term.
We don't talk about the dangers of high blood sugars because that's such an acute need to make sure you don't have complications with the low blood sugars. But I want to acknowledge this because we're dealing and we're talking about aging with cystic fibrosis. And there's the medical jargon that we were starting to mention, the microvascular and macrovascular complications. But like very simply put, like we're talking about heart disease, kidney disease that we call diabetic nephropathy, the GI manifestations like people have slowed motility in their GI tract. They can lose feeling in their limbs. And that's why people might know about where people have their like a filament poke on their toes to make sure that they have feeling in their toes. But especially I wanted to bring this up because people with CF who may not have imagined living long may have felt that even though they knew about these long-term risk factors that I want you to expand on, that controlling the blood sugar, that they weren't going to live long enough to feel some of those symptoms or have some of those complications. And the fact that when you're diagnosing somebody, you're already freaking them out about all these other things. So maybe the low blood sugars is what you're really focusing on. So when you're diagnosing someone new, you may not get to some of those complications of sustained hyperglycemia or high blood sugars. So how do you educate people? Like how do you sustain that conversation and talk about those time-dependent complications?
Yeah. I'll tell you, actually, it's a really good point because when you're telling someone they have diabetes and you're trying to take in all the things you have to do, it's not the best time. Like, oh, and, think about this 10 years ahead. You got to look right now and like, how are we going to survive right now? But I do think that over time, those are the conversations that kind of have to happen. It's funny, when I first started in CF, taking care of people with CF, the teaching was, oh, people with CF don't get microvascular complications. I remember thinking, why not? They're not like, I don't, but it really was that we weren't screening because it just didn't seem like that was going to be, that's maybe cause of a lot of problems in people with type 1 and type 2, but not in CF. And so everything has changed now. And so we really are, I think, starting to do a much better job about educating people with CF about these complications and screening for them, checking cholesterol, especially in our aging population. I think that in the context of that annual screening that we do for everyone else with diabetes, that's when we should also be talking about this for people with CF.
Have you guys heard of med student syndrome? I'm sure you have. Where med students like become hypochondriacs and they think they're getting everything they're studying. I'm like, I'm going to call you tomorrow immediately for a vascular study.
No, yeah, absolutely. No,
Might
that's why
have
maybe we
that.
don't want to bring things up right that first day because they're like, oh my God, I have got all of it.
I
I've
have
got
it
all of it,
all.
everything.
Yep.
You've brought it up a couple times. Can you explain how the screening process works and how often you do it for CF patients?
So the CF Foundation recommends the 2-hour oral glucose tolerance test be done for everyone over the age of 10 every single year. And as I'm sure everyone knows, it's just a terrible test. You come in fasting, you drink this really disgusting sugar drink, you sit around for 2 hours, they check your blood 2 to 3 times over that period. And it's hard because for many times, that's not what you do in real life. You're not drinking 75 grams of straight sugar within 2 minutes. And so, but This test has been shown in many studies to predict things that are important for us in CF, and that's lung function and nutritional status. And so we don't have any other testing right now that has really had those outcomes pinned to cutoffs so that we know for sure that this is actually going to be meaningful. And yes, so that's where we're at right now, where the OGTT is the best that we have, but it's a terrible test. Nobody wants to get it done. Our screening rates are very low, and really we need better ways. And I can say that there's a lot of ongoing research trying to figure out what these other potential options for screening could be.
Why can't you just do an A1C?
I love that question. Because you're right, A1C, it's a measure of average blood sugar over the past 3 months. And this is how we diagnose diabetes in literally every other patient population. In CF, it's helpful if it's high. But if it's normal, so if it's 6.5 or above, then we can say if you repeat it twice and it's still above 6.5 or above, then we can say yes, it's diabetes. But if it's below that, then remember I told you about that really unique glucose pattern that people with CFRD have, where they have like highs and they come down. It's like a big wave, and they're usually overnight. Blood sugars are okay. Their average blood sugar, if you take the highs and the lows and you average it, their average is normal. And an A1C is a measure of average blood sugar over
Right.
3 months. And so you'll
Okay.
miss this early CFRD if you just use A1C. Now, there are some studies coming out that are saying we could have our own threshold, like 5.8, 5.9. If you're below that, then you're unlikely to have diabetes, and use that as a first pass test for who needs an OGTT. They're doing that actually in Canada. And that could be an option. I will say with lung transplant, a lot of times that for whatever reason that I don't fully understand, A1C tends to be falsely even lower. And so I don't think we can use that as a strategy in people with CF and lung transplant.
Because of the topic that we're on, I wanted to go back to Lauren because as we're getting to know each other, I found out that she is terrified of needles. So I wanted you to sort of talk
I'm
about that.
very
Yeah.
terrified of needles. So when I was first diagnosed, I wouldn't look at the shot. And I don't know if you were ever there, Melissa, when I wouldn't look at it. But they would be
She
like,
remembers,
okay, you
I'm
have to
sure.
give yourself a shot and you have to look at it or we can't release you. And I'm like, okay, where's the shot? I don't know where it is. And so I'd look away and they were like, you can't do that. I also hated finger pricking, but that one wasn't as bad. So I'm curious with all the new technology that's come out with the CGMs, chronic glucose monitors, and insulin pumps, how has that technology improved people's lives and how does it help them?
Yes, at least with the continuous glucose monitors, you don't need to see the needle. Nothing sharp.
Thank
Can't see
God
it.
for that.
Yes, I feel like I've seen firsthand just how helpful these devices can be, starting with continuous glucose monitor, CGM. These have been shown in studies in type 1 and type 2 diabetes to improve glucose control. We don't have those exact same studies in CFRD, but I think I can say from just firsthand, being able to see your blood sugar without having to stop and prick your finger and do a glucometer and all that has just been so helpful. And then being able to see patterns for me as an endocrinologist, I can pull up someone's CGM data to see exactly what we need to do to try to help make things better. And it's just that knowing. And people tell me that I consider CGM kind of like a gateway drug when it comes to technology, where I'm like, just try it. And then they try it and they're like, I can't live without it. And so then and then after they do that, then I'm like, okay, now we're ready to talk about insulin pumps. So let's go to the next step. So now the insulin pumps are connected to the CGMs. And so they can automatically adjust the insulin delivery based on input and based on what the blood sugars are, what they are, where they're going. And I think that has really helped to offload some of the burden that we see in CFRD.
Really quickly, the CGMs for diagnosis or when someone's hemoglobin A1C is 5.8. OGTT is one thing, but I know that you told me that you really love to see someone wear a CGM for a couple weeks and see what their blood sugars do.
Yeah, I think that CGM is so helpful because I can see exactly what's going on their usual diet. And it tells me if I need to start insulin, I can see how. Are the fasting blood sugars high enough that they need long acting insulin? Is it just high blood sugars after eating? Is it really for insulin to work after meals? You need to have at least 3 hours of blood sugars being high. If your blood sugar is only high for an hour, insulin is just not going to help. And I can get all of that from CGM. The problem is that we don't know what cutoffs to use. I feel like I can eyeball a CGM and be like, yes, that's it. But that doesn't really work as a screening tool. And we need studies really to really pin down CGM outcomes to CF outcomes to really know how best to use it for screening.
Would it be helpful if you like knew exactly what someone was eating and what the carb were that they were eating, or does it make a difference?
I don't think it really matters. I'll be honest. Yeah, I like to treat the person and not the numbers. And what's happening is more important than what's causing it.
Just a continuation of the technology, and you're never going to be able to do this in 1 minute. But the bionic pancreas, tell us about that.
In 1 minute, I'm ready. To be totally honest, the reason that we started this study, the reason I'm so excited about it is for everything we talked about with this diagnosis of diabetes. It causes such burden. There's so much time and effort that goes into managing diabetes. The bionic pancreas is the most automated of all the devices out there. You don't have to count your carbs. You don't have to tell it to give more insulin when your blood sugars are high. You don't need settings that you have to adjust all the time. It learns how much insulin you need, and then it will constantly keep learning when that changes, which happens a lot in people with CF. You get sick, you need more insulin. You're healthy, you need less. It will learn all of these things and just make it easier. So one of our participants told us that when she did our first clinical trial with the bionic pancreas, she has CFRD for many years. And she said that it was the first time that she felt like she was taking a vacation from diabetes. And that is why we're doing the study, because you guys deserve a vacation.
You're right, we
Absolutely.
do. Can I ask a question about that? When somebody like me who has a bad back goes in for a steroid shot, even I know all my profiles and all my, I'm an expert on myself. It goes haywire. It takes me like 3 weeks to reel it in. And by the time I figured it out, the steroid shot's wearing off and so on and so forth. So does the AI figure it out?
So it's not AI per se, but
Or
yes. So
the,
it's basically continuously seeing what different glucose patterns are doing and how much insulin you're responding to.
Mhm.
And so the data that we have suggests that really within 24 hours, it will adapt to a change like that. And then when it starts to wear off, it'll continuously keep learning, okay, need less insulin all the time. And yeah, so that's why I think it would be really helpful for those cases or for someone who needs a 5-day steroid taper. So hard. And it just makes things easier when you have something else that's helping in the background.
Andre, I was thinking that you're thinking this is like a chat GPT run, or actually, wait, now it's DeepSeek run bionic pancreas.
Just stick Chat GPT and a glucose monitor and
Figure it out.
make it learn Photoshop, and we're all set.
So medications like Ozempic and Wegovy, and for us scientists, glucagon peptide, one glucose-dependent insulinotropic polypeptide, hormones that are drugs that regulate blood sugar levels. There's a lot of information out there for like its weight loss benefits, but it's really been developed for people with diabetes. And now I know that there's increasing studies in CF, but those drugs, along with those SGLT2, also known sodium glucose cotransporter 2 molecules, I am sure you're being asked to start people on these medications. And so I think that they really do seem to be great drugs. Like, how are you using it? What's the correct way? What's too much, not enough?
No, this is such a great question. These are great medications. We're finding now that GLP-1s they're good for the heart, good for the kidneys, good for the liver. I think these are great medications. SGLT2s, so good for the kidneys. These are really good medications. And I absolutely am being asked about them. I'm prescribing them for people with CF. And I think that, but it's important that we take this on an individual basis because, so these medications, I usually only use them for people who are obese with CF or who are in the overweight range and I'm worried about their heart and their kidneys or something like that. And because it does cause weight loss and we need to be really careful in people with CF. We don't want to overdo it and cause a low BMI because we know that directly affects lung function. So I think, so for people who have a BMI in the overweight or obese range, I absolutely will consider it. Now, the risks that we need to think about are a lot of people with CF have significant problems with GI symptoms. And this causes a lot of nausea, especially in the beginning. It can cause constipation. One thing that I counsel my patients on when I'm starting these medications is the risk of DIOS, so distal intestinal obstruction syndrome. Only in CF. It's never been shown with these medications, but these medicines slow GI transit. And so that could be a unique complication in CF, and we need to be watchful of that. Make sure people are staying hydrated and that treating constipation really aggressively with these medications. That's one thing that I think is really important to highlight specific to CF. But many people with CF or CFD already have delayed gastric emptying. This will make that worse. So if you have really severe gastroparesis, this is probably not a good medication for you. There'll be food sitting in your stomach for weeks. The other thing I counsel people on is if you're going to need a procedure, colonoscopy, bronchoscopy, you got to stop it way in advance so that, again, you don't go into your procedure with stuff in your stomach. And I think that's unique to CF too. And then also there's a potential risk for pancreatitis that I think most people with CF don't have pancreatitis, but some do, especially with pancreatic sufficient patients. And so it's something to keep an eye out. And then just dehydration, making sure that people don't get dehydrated. But I think these are great medications. I use them in people who do not have diabetes. I find that in people who do have CFRD, we can use these medications and it can help blood sugars, reduce insulin requirement. And then SGLT2 inhibitors, I've been using those also, particularly for people who are having signs of protein in their urine, because this medication can actually really help to prevent damage from happening to the kidneys. And again, we have to be careful with these, in particular with CF, because of this risk of dehydration. There can be a risk of UTIs or infection. And so I think it is, and also it can increase the risk of diabetic ketoacidosis in people with type 2 diabetes who don't usually get that. And see, people with CFRD don't usually get diabetic ketoacidosis, but maybe they could. And so I think these are all the things that we have to be very careful about when we're thinking about prescribing these medications.
Yeah, no, that's really great. And it's another topic for another podcast, but you can have silent kidney disease and not know it. And the SGLT2s may really be helpful for a lot of people with CF. It's going to be great when we have more and more information and more people understanding and using it safely. So I think that we're going to try to wrap up here, but I do want to touch on something I know people want to know about: modulators. Lauren, I'm going to just direct this to you. You started modulators and you were diagnosed with diabetes prior to that. How did modulators change your management of diabetes? And Melissa, I would love for you to comment on that.
Yeah, so when I was diagnosed, I was actually on Symdeko at the time. And Orkambi was my miracle drug. And so when they told me I had to switch to Symdeko, it didn't go very well. I didn't feel healthy when I was on Symdeko. I, in my brain, told myself that it didn't work as well, so I didn't take it frequently. My health was already declining when I was diagnosed. And in the beginning, I didn't really notice a huge difference in taking my modulators or not. But once I started Trikafta, I could tell it was a whole new world for me. And they definitely work in tandem. If I'm not taking my Trikafta, then my blood sugars suffer and vice versa. And I definitely think that the modulators have greatly impacted how I manage my diabetes and my CF. And I really don't think I would be as healthy as I am if I didn't have both of them together working. And so my question would be, How do CFTR modulators impact those who already have CFRD?
Yeah, it's a great question. So we did actually a study in Boston where we threw CGMs on people before and after they started Trikafta. And although the pandemic definitely got in the way of that study, but we actually did see that blood sugars got better. And it's hard to know exactly why. Is it people are healthier, there's less inflammation, less insulin resistance, they're more active? There's a whole bunch of different reasons why that might be. And this was actually also looked at in the PROMISE study, which is a multi-center observational study following people after Trikafta. And it's really interesting because they found that hemoglobin A1C got a little better. They didn't use CGM in that study, but they also did OGTTs, and those didn't really change. Categories of people who, if people had diabetes going in, that didn't get better with modulators. They still had diabetes, even with that. And so I think the big question is going to be starting modulators really young. If we can start in babies and maybe offset whatever is happening in the pancreas early on, could that potentially work to prevent diabetes? I think that's an open question.
Yeah. That's we're looking at what would be the cost savings of we're now starting moms who know that they're going to have a child with CF on these drugs. And is there any reason to spend that much money on a mom who doesn't have CF, who is going to have a kid with cystic fibrosis? And it's the cost analysis we have to include is diabetes. If we can make sure they don't get CF-related diabetes, that is a huge cost in quality of life, but also medical costs. So I think that's a really great place for us to end our conversation with diabetes with you. And we haven't even, it's the tip of the iceberg, but that's all the time we have for today. And I can't thank you enough, Melissa, for letting us geek out about CF-related diabetes with you today. And it's just been amazing having you here. But as I say that, we're not done with you. So, yeah.
And we'll
I would
probably
love
bring
to
you
come
back at some
back.
point too.
Yes. Oh my gosh.
Yeah,
Anytime.
we're not done with you for having a more conversation on diabetes, but we're also not done with you on this podcast. So we are, obviously, this is our first podcast. We have no idea how we're going to do the second one, but we're learning. We're like your insulin pump. We're learning as we go. And we are planning on ending every interview, and this may sound really silly, but with a little segment we're going to call, What Does That Have to Do with Anything? So we're going to take 60 seconds to answer a hodgepodge of as many CF-related or mostly unrelated questions as you can. And we hope to one day have prizes. We already said that we think you're going to win a prize at the end of the year. So maybe this will put you over the top. So we're going to start these questions. And so are you ready?
And good luck.
Well, okay,
Yes,
random
we're
amount of
learning.
time on the
We're
clock,
learning.
and here we go.
Okay, first question. Is it better to cut your sandwich diagonally to create triangles or horizontally and create two rectangles, and why?
Rectangles, because that's how I always do it.
Which one tastes better, the triangles or the rectangles?
Rectangles.
Okay, all right. You have to go with rectangles. That's the way you do it. All right, picture that sandwich. How many carbs are in it?
Which kind of sandwich?
The one you just cut, and the one that's
The rectangular one.
rectangle.
35 grams.
All right, that sounds right. Who on the podcast team just got a new puppy? There's three of us here, so you've got 33% chance.
Lauren, no. Andrea.
Wrong.
Andrea.
She's got new puppy. What's the name?
Mabel.
Mabel.
Oh, sorry. I think that was from Melissa.
No, that was for you, Andrea. I was hoping you could share that with our audience who's getting to know you. True or false? Our podcast already has 23,000 followers.
True. No, that was just wishful
Sadly,
thinking.
sadly,
Okay.
no.
Well,
We wish.
we actually haven't posted anything. So in our defense and in your defense, we haven't posted anything. And who knows? Like right now, there's no followers to be had.
Okay.
What is the capital of Montana?
I don't know a single city in Montana.
Next question. You don't know a single city. You do. You know
Oh my
one.
God.
Helena, Montana. Haven't you seen Yellowstone?
All right.
She
We
needs
may,
to now.
hopefully, we
Jeez.
haven't offended anyone on
Doctors, they sound
Montana.
smart, and they are.
I just met the nicest people from Montana, so hopefully they're not listening. Can a cronut give you diabetes?
No,
That's good to know.
I'm confident about that. Yes.
All right. Billie
Not one.
Eilish or Taylor Swift?
Wait, it's a given.
Billie Eilish or Taylor Swift?
Oh, Taylor Swift. Oh,
Okay. Did
easy.
you go? Did
Okay,
you go your
Good
Esther?
choice.
Thank you.
that's 60 seconds or so.
Wait, I had one last question.
Oh.
Cats or dogs? What's better? Who's
Dogs.
better? Okay. All right.
And I have one
Susan,
personal
Susan.
question. Pineapple on pizza, yay or nay?
Yay, for sure.
Can't have her back.
I lost you at the pineapple. Ah.
All right.
Thank you for that calculation. Andrea just told me that you got 47,000 points. So that's amazing. That's the high score.
And I'm
But-
winning so far.
Yeah. You're the
Yeah.
first person and you've got the high score. But anyway, we are just so thrilled that you joined us today for the first podcast as we're like figuring things out ourselves, and you were brave to do it. You were kind to do it. You spent so much time with us. We know that there's way more to tap in that amazing brain of yours, and we look forward to having you join us again. And hopefully we'll have it figured out even better by then.
I only ask that I get to be your first follower.
Okay.
Oh, of course.
Okay, well,
I get to be number one.
stay
Okay,
tuned.
that's my
stay
only
tuned
request.
for our
Okay.
outro.
We can do that. Well, Melissa, thank you. And we look forward to connecting again. I know I'm going to connect with you probably tomorrow. We look forward to connecting as a group as well.
Well, guys, I guess we should get into the inaugural segment of What's Up With That, where we take a little bit of time to talk about what we learned from Melissa and things that people don't normally get to hear when they're first getting diagnosed. I guess I'll go first. The biggest thing I learned is that there are so many dangers of high blood sugars that people glaze over initially, even though they are just as important as lower blood sugars. And I also learned that Ozempic was originally made for diabetes. I didn't know where it came from. So that was fascinating to me as well.
I've been really loving the chronic glucose monitor, and I was hoping that Melissa would say that was going to be another way of diagnosing people with CF, with CFRD. And I love her answer and really understand why that is not still another avenue, because OGTTs, those oral glucose tolerance tests, are so hard. Everyone pushes back. We send someone out the door with that request and a prescription. And I would say that it happens maybe 40% of the time after we send someone home with instructions on doing it or asking them to do it. A CGM is, I thought, would be a nice way to replace OGTT, but it's just not prime time yet.
I still think we should look into getting a better juice flavor for that test because it is a disgusting drink, especially if you go early in the morning. It doesn't go down easy.
And I forgot to ask this question, but there was a time where glucola, or that drink, that disgusting drink, although some people like it, wasn't available. And so we were having people drink a can of Coke or 2 cans of Coke to get 85 grams of carbs. And sometimes I hear some people take a mouthful of Skittles. Now, I'm not sure if that's appropriate, and I was hoping to ask her that question. So I'm going to say, what's up with that without having an answer for you guys?
I didn't learn anything because I've had diabetes for 20 years and I know
Ha!
everything.
Ha!
No, I think some things I learned from our questions. The same thing about the GLP ones. Is that what they're called? That they were developed for diabetes initially and that they could help people. I did not know that. I'm still not entirely sure I could explain the difference between type 1, type 2, and CFRD because it still goes with the way my pediatric pulmonologist just said, your pancreas just pooped out. But I did learn a little bit more about the more sciencey reasons behind it. I agree with you, Lauren, though, that we should really get a number like everybody else. And if 3's taken, there's 4,
Give us
there's
4.
5. But most of all, I feel like I have a better overall understanding about like where it's coming from, where it's going, and what everybody's trying to do to make it a better experience for us. For that, I found the whole episode just riveting. My head's exploding right now with all this stuff.
That was a lot of information to take in a short amount of time. And all I can say is I am super excited for this bionic pancreas. I would love it now if possible. Then the next year or so would be great too.
And to hear about that person in the trial, and I've heard her say this, just say, I felt like I was on vacation. I wish that for both of you.
I also heard that somebody refused to give it back. Not today, but my endocrinologist said that they had really a lot of trouble getting it back from somebody.
I'd refuse. I wouldn't give it back.
Nobody can fact check me on that because I'm not going to reveal.
You're like,
that
lost it.
conversation. Okay. So
But I'm going to still need that part. Great podcast. I know this is our first one, but I thought it was great.
fingers crossed.
Let's do it again in a month.
Until next time.
Get a little older.
Live a little bolder.
We are working hard to provide meaningful information to a deserving CF community, information you won't find anywhere else. If you'd like to help us grow, we'd greatly appreciate it if you would follow us on Apple Podcasts, Spotify, or wherever you get your podcasts, so you never miss an episode. Want to go all in? Leave us a rating and a review. It helps people find us and makes a big difference. If you found this episode helpful, please share it with a friend, family member, caregiver, or provider who might also want to hear it. This helps you, it helps them, and it helps us spread the word to those who need to hear it most. It's a Long Story is produced by me, Andrea Gavin Becker, and is hosted by Dr. Ahmet Uluer and Lauren Harvey. Additional editing and production support is provided by the team at Resonate Recordings. Until next time,
Get a little older.
Live a little bolder.